In this video, we will study about oral submucous fibrosis. So these are the contents. We will cover the introductory part, then definition, epidemiology, nomenclature, classification, etiopathogenesis, clinical features, histopathology, differential diagnosis, special investigations, malignant potential, and finally treatment and management. Coming to introduction, oral mucous membrane is a unique area of the body which is continuously exposed to various kinds of stresses such as heat, cold, microorganisms, chemicals, and mechanical irritations. In response to these stresses, both epithelium and connective tissue layers of the oral mucosa exhibit acute and chronic reactive changes. One such reaction of the collagen of oral mucosa to areca nut is oral submucous fibrosis. OSMF is a chronic disease of insidious onset and a prevailing potentially malignant disorder characterized by juxtaepithelial inflammatory reaction along with mucosal fibrosis. OSMF is characterized by deposition of dense collagen in the connective tissue. It was first described by Schwartz as Atrophica idiopathic mucosae oris in 1952 among 5 Indian females in Kenya. In 1953, Joshi from Bombay redesignated the condition as submucous fibrosis. So coming to definition, the most widely accepted definition is given by Pinbog, JJ and Shearseth in the year 1966, which states that OSMF is an insidious chronic disease affecting any part of the oral cavity and sometimes the pharynx. Although occasionally preceded by and or associated with vesicle formation, it is always associated with juxtaepithelial inflammatory reaction followed by a fibroelastic change of the lamina propria with epithelial atrophy leading to stiffness of the oral mucosa and causing trismus and inability to eat. So coming to epidemiology, OSMF was first described in the early 1950s. It is a potentially malignant disease which is predominantly seen in people of Asian descent. The disease is predominantly seen in India, Bangladesh, that is the South Asian countries. And several case series are reported among some Asian immigrants to the UK and Southeast Asian Africas also. Pinbog in the year 1980 quoted it as the most exclusively occurring among Indians, Pakistanis and Burmese. The condition was first described in ancient Indian manuscript by Sushruta. The prevalence of this condition in Indian subcontinent is a reflection of the food, culture or religious habits. It is more prevalent among younger individuals, that is within the age group of 15 to 35 years of age. The male to female predilection shows that males are predominantly more affected as compared to females, and the ratio is 2.3:1. These are the various nomenclatures of OSMF. It was previously called as Atrophica idiopathica mucosa oris by Schwartz, then submucous fibrosis of palate and pillars by Joshi, diffuse oral submucous fibrosis by Lal, and so on. You can refer to the slide for your further understanding of the nomenclature. Now coming to classification of OSMF. Based on clinical findings, classification was given by Pinbog in the year 1989 as 3 stages, stage 1, 2 and 3. Stage 1 is stomatitis, erythematous mucosa, vesicle, ulcers and petechiae formation of the mouth. Then stage 2 is fibrosis in healing vesicles and ulcers leading to blanching, palpable bands, mottled marble-like appearance. And stage 3 is sequelae of OSMF along with leukoplakia, speech and hearing deficit. Then Eli del R in the year 1995. On the basis of interincisal distance, they classified OSMF into 4 groups, group 1, 2, 3 and 4. Group 1 is when interincisal distance is more than 35 millimeter. Group 2 is when interincisal distance is between 30 and 35 millimeter. Group 3 when it is between 20 and 30 millimeter. And Group 4 when it is less than 20 millimeter. Hyder SM in the year 2000, they classified OSMF into clinical stage and as per functional stage. So according to clinical stage, it is subclassified into stage 1, 2 and 3. Stage 1 only fascial bands are palpable. Stage 2 only fascial and buccal bands are palpable, whereas in stage 3 fascial, buccal as well as the labial bands are also palpable. In the functional stage, he classified OSMF into three stages again: stage 1, 2 and 3. Stage 1 is when the mouth opening is more than or equal to 20 millimeter. Stage 2 is when the mouth opening is around 11 to 19 millimeter. Stage 3 is when the mouth opening is less than or equal to 10 millimeter. Prakash R et al., based on morphologic variants of soft palate, they subclassified it into type 1, 2, 3, 4, 5 and 6. Then the histological classification was given by Baylor as grade 1, which states that epithelium shows hyperkeratosis, intracellular edema, little basal cell hyperplasia, and rater ridges are present. In grade 2, epithelium undergoes atrophy. Rater ridges are less prominent. Connective tissue shows thickened collagen bundles, less cellularity, fibrosed blood vessels with moderate amount of hyalinization. Grade 3 shows marked atrophy of epithelium, absence of rater ridges, connective tissue showing abundant hyalinization, cellularity absent in connective tissue. So these are the various grades of OSMF as seen histologically in 10x and 40x. Now coming to etiopathogenesis of OSMF. So it is a multifactorial disease. There are certain local factors like chilies and areca nut and systemic factors such as nutritional deficiency, genetic predisposition and autoimmunity. Epidemiological and in vitro experimental studies have shown that chewing areca nut is one of the major etiological factors. Chilies contain capsaicin. So capsaicin is an active principal mild irritant and it brings about epithelial and connective tissue changes in OSMF patients. So this is the most, the capsaicin present in chilies is the main culprit causing OSMF. It also causes elastic degeneration or degradation of collagen fibers and ultrastructurally partial or complete degeneration of collagen into elastin-like filaments, sheets or dense amorphous material. Mutagenic and metagenic elements, they enhance the tumorigenicity of tobacco in experimental animals. It increases the risk of cancers in the upper aerodigestive tract in dose-dependent manner. So these chilies, the capsaicin element present in chilies, they are mutagenic also. That is, they cause mutation of the oral epithelial cells, leading to tumorigenicity. Nutritional deficiency is a secondary factor. OSMF patients, they cannot tolerate spicy food, and as the opening of the mouth becomes smaller day by day, so their daily intake of food is decreased, which leads to further nutritional deficiencies. Now coming to areca nut. Areca nut contains 4 kinds of alkaloids, that are arecolin, arikidin, guavacin and guavacolin. Amongst these 4 alkaloids, arecolin is the main agent or the main culprit which causes OSMF. It also contains flavonoid components like tannins and catechins. The fibroblastic proliferation and increased collagen formation leads to OSMF. So there is increase in collagen formation, whereas the collagen that has been previously formed is not degraded. There is no degradation of collagen fibers, only there is continuous growth of more and more collagen fibers, which lead to ultimately thickening or stiffening of the oral mucous membrane. So basically the arecolin of areca nut, they inhibit the collagenase enzyme. The main function of the collagenase enzyme is to break down the collagen fiber so that new collagen fibers can develop. It is the body's own system. But what happens is that the arecolin, they inhibit the collagenases. So hence new collagen is continuously formed with no degradation of the old collagen present. So here you can see the flow chart. Arecolin along with slaked lime, it causes hydrolysis. It gets converted to arikidin when it is taken along with slaked lime. It leads to fibroblast stimulation and proliferation, leading to increased collagen synthesis. Stabilization of collagen by tannins and catechins, polyphenols. Tannin are also present in areca nut, and the role of tannin is to inhibit collagenase, leading to decreased or reduced collagen degradation. So along with arecolin, Tannin and arecolin lead to degradation of collagen and increased production of collagen fibers. Now coming to clinical features of OSMF. Early OSMF shows burning sensation, blisters, ulceration, excessive salivation, defective gustatory sensation and dryness of mouth, whereas advanced OSMF shows blanching of the mucosa, slightly opacity, white fibrous bands which are present vertically, fixation, shortening or deviation of the uvula, impairment of tongue movements, inability to blow or whistle, difficulty in swelling, and a nasal tone. In the first figure, you can see blanching over the left buccal mucosa, and in the second image, you can see blanching on the ventral surface of the tongue, floor of the mouth. Ultimately, it will lead to restricted movement of the tongue. Decreased mouth opening in oral submucous fibrosis patient. The soft palate and facial pillars have become red. Here you can see soft palate showing blanching and shrunken uvula is seen in the posterior part. And in the image present below that, you can see white patches or opacity of the buccal mucosa, typical sign of leukoplakia. Coming to histopathology, epithelial changes. Histological findings in OSMF cases were found to vary depending on the clinical severity of the cases and the site of biopsy taken. The observed epithelial changes are secondary to changes in connective tissue. The findings range from normal to atrophic and hyperplastic epithelium. Painborg and Shearseth observed marked changes in the form of atrophy of epithelium with loss of retipex in 90% of cases as compared to normal oral mucosa. So basically what you have to remember is there will be atrophy of the epithelium with loss of retipex. The atrophic epithelium also exhibits intracellular edema, signet rings and epithelial atypia. Epithelial keratinization, especially the tendency of atrophic and hyperplastic epithelium to show keratinization, was higher when compared to the normal counterpart. Increased mitotic activities were evident in a small number of cases. Coming to connective tissue changes, Pinbock et al. Have described four consecutive stages in submucous fibrosis cases based on sections stained with hematoxylin and eosin. The changes were presence or absence of edema, nature of the collagen bundles. So these are the criteria on which they have classified the various changes seen in OSMF cases, like overall fibroblastic response, state of the blood vessels, predominant cell type in the inflammatory exudate. So in very early stage, there will be fine fibrillar collagen dispersed with marked edema and strong fibroblastic response, which shows plump young fibroblast containing abundant cytoplasm. Blood vessels are occasionally normal, but more often they are dilated and congested. Inflammatory cells like PMNL, that is polymorphonuclear leukocytes, with occasional eosinophils are often present. In the early stages, in this stage, juxtaepithelial area shows early hyalinization. The collagen is still seen as separate bundles which are thickened. Plump young fibroblasts are present in moderate numbers. The blood vessels are often dilated and congested. The inflammatory cells are mostly lymphocytes, eosinophils, and the occasional plasma cells. Moderately advanced stage, here the collagen is moderately hyalinized. The amorphous change starts from the juxtaepithelial basement membrane. Occasionally, thickened collagen bundles are still seen separated by light residual edema. The adult fibroblast cells have elongated spindle-shaped nuclei and scanty cytoplasm. Blood vessels are either normal or constricted as a result of increased surrounding tissue. The inflammatory exudate consists of lymphocytes, plasma cells, and occasional eosinophils. In advanced stages, collagen is completely hyalinized and is seen as a smooth sheet with no distinct bundles or edema. Hyalinized connective tissue becomes hypocellular within elongated cells. Blood vessels are completely obliterated or narrowed. The inflammatory exudate consists of lymphocytes and plasma cells and occasional eosinophils. Interestingly, the melanin-containing cells in the lamina propria are surrounded by dense collagen, which explains the clinically observed loss of pigmentation. So coming to Khanna and Andrade classification, which is very important. They have grouped OSMF into four groups based on histopathologic features. That is group 1, 2, 3 and 4. In group 1, we can see very early changes. The common symptoms are burning sensation in the mouth, acute ulceration and recurrent stomatitis. And they are not associated with mouth opening limitation. The histology shows fine fibrillar collagen network interspersed with marked edema. Blood vessels are dilated and congested. There is large aggregate of plump young fibroblasts present with abundant cytoplasm. Inflammatory cells mainly consist of polymorphonuclear leukocytes with few eosinophils, and the epithelium is normal. In group 2, they are the early cases. Here we can see the buccal mucosa as mottled and marble-like. There are widespread sheets of fibrosis which are palpable, and patients will come with an interincisal distance of around 26 to 35 millimeter. The histology shows juxtaepithelial hyalinization. Collagen are present as thickened but separate bundles. Blood vessels dilated and congested. Young fibroblasts are seen in moderate number. Inflammatory cells mainly consist of polymorphonuclear leukocytes with few eosinophils and occasional plasma cells. There is flattening or shortening of epithelial retinal ridges which are evident with varying degree of keratinization. Group 3 are the moderate to advanced cases. Trismus is evident here with interincisal distance of 15 to 25 millimeter. Buccal mucosa appears pale and it is firmly attached to the underlying tissues. There will be atrophy of the vermilion border of the lips. Vertical fibrous bands are palpable at the soft palate, pterygomandibular raphe, and anterior facial pillars. Histology shows juxtaepithelial hyalinization, thickened collagen bundles which are faintly discernible, separated by very slightly residual edema. Blood vessels are mostly constricted. Mature fibroblasts with scanty cytoplasm and spindle-shaped nuclei are present. Coming to group 4 is divided into two separate parts, that is group 4A and 4B. They are the advanced cases. Here in group 4A, we can see trismus with severe interincisal distance of less than 15 millimeter. Fossils are thickened, shortened and firm on palpation. Uvula is shrunken, appears as small fibrous bud. Tongue movements are limited. On palpation of lips, circular band are felt around the entire mouth. In group 4B, we can see advanced cases with pre-malignant and malignant changes. There will be hyperkeratosis, leukoplakia or squamous cell carcinoma. In the histological section, we can see collagen, which are hyalinized as smooth sheet, extensive fibrosis leading to obliteration of the mucosal blood vessels and elimination of the melanocytes. Fibroblasts are markedly absent with hyalinization zones, total loss of epithelial retinal pegs, mild to moderate ATP are present, extensive degeneration of muscle fibers are evident. So what are the differential diagnoses of OSMF? They are scleroderma, fibroma, generalized fibromatosis, anemia, and amyloidosis. The malignant potential of OSMF. The precancerous nature of OSMF was first discovered by Paymaster in 1956 when he observed slow growing squamous cell carcinoma in 1/3 of the patients with the disease. This was confirmed with various groups, and Pinbock put forward 5 criteria to prove that the disease is precancerous. They included high occurrence of OSF in oral cancer patients, higher incidence of squamous cell carcinoma in patients with OSMF, histological diagnosis of cancer without any clinical suspicion of OSMF, high frequency of epithelial dysplasia, and higher prevalence of leukoplakia among OSMF. The malignant transformation of OSMF was found to be in the range of 7 to 13% as given by Tilakaratne in the year 2006. According to long-term follow-up studies, a transformation rate of 7.6% over a period of 17 years was reported by Murthy et al. In 1985.